So we're gonna sit here and let you in the seat.
Stand or whatever you want to do.
I'm Kenny. That's me. Open Arms Clinic. I don't know any of you. Awesome. How about Open Arms Clinic? Anybody heard? One. Anybody no plans to go there and do a Super Saturday? Anybody heard of this business? There's one tomorrow. Nobody's doing that tomorrow? Okay, fair enough.
What is it?
Well, it's a charitable, okay, so it's a Super Saturday for women. It's cervical cancer screens for the uninsured population. So all the charitable clinics here in the city, if you've got a female that needs to have that screening done, they can refer to Super Saturday Clinic and once a quarter bag. Somebody comes in and takes over the clinic and does like 50 PAPs. So it's just a good opportunity to get that skill check. Another one. That's Super Saturday. Okay, and you guys are almost done. She said that you guys are like almost done. So you're what, 9 months into DIDAC? Kind of over it. But definitely like in a groove, like you got the testing thing figured out, anxiety's come down. As it applies to DIDAC, it's about to go back up because rotations are starting. You got your rotations scheduled yet? Oh, you're waiting on that. Have you made your preference? Oh, you're waiting on that. Have you thought about, how do you do it? Do they just, you're going to have rotations in these areas, or do you get to pick some, or you have a preference, or you don't know?
No idea.
They'll get a Qualtrics survey.
Yeah.
They've got 8 core rotations that they have to have, and then they'll basically have 5 electives, and they'll get to rank their preference for their electives.
Same way that we did it. So
Right?
Sorry, I'm probably jumping the gun on that. Just curious.
No, it's exciting. It's an exciting time.
Yeah, it is. Okay. Well, so diverticular disease is what I'm here to talk about today. Where's the header? There it is. And I have gone through this forward and backwards. I don't have 2 hours worth of information, even given room for questions, so I'm going to try not to rush too much. If you have questions, please ask. 2 possible scenarios. I will know the answer and spit it out promptly.
Kenny, I forgot to tell you, the little hot dog looking, the long remote will advance your, that will advance one.
Looks like most hot dogs
It doesn't look like a biscuit.
have. Closer to a hot dog than this.
There's also a pointer stick.
I can't wait.
Now, I showed you the biscuit.
So like I said, if you have a question, two outcomes. I'll know the answer and spit it out quickly, or I'll have no clue at all, and I'll just make a note and get back. Right. Test is Monday. When was your last test? 2 weeks ago.
Still GI.
Okay. Still GI? All right. Okay. I'd like to see you know who I'm talking to. So here we go. Me again. Review of relevant anatomy, always, right? This is exactly what your colon looks like. It's actually I think this is a photograph. No, it's a drawing. Okay. So you guys have seen this, right? So cecum, ascending, hepatic flexure, all this stuff. None of this is new. Does anybody need to camp out here and talk about this? Okay. So we'll go to the next one. Colon and rectum, consider large intestine, U-shaped tube, 6 feet in length. The cecum, ascending. One thing in reviewing this as I was getting ready that was really interesting, the ascending is retroperitoneal, and the transverse colon is peritoneal, and then back to retroperitoneal, which I don't remember that in anatomy whenever I went through it. But just interesting, it probably won't, one of those factoids that you might never have no idea. But, and this is important too, right? So with abdominal stuff, I was trying to point at the text, whatever. The mid-transverse colon may sag as low as the umbilicus. Again, another revelation that I had preparing this, because abdominal pain is kind of all over the place. And so you think of the quadrants, like, and what's in the quadrants and what structures are there. Well, your transverse colon can be down by your belly button, so have fun with that. Descending back to retroperitoneal structure on the left side of the abdomen, sigmoid colon for the S shape. That's pelvis. So stores gas because of the bend. It can expel gas without expelling feces. Exciting to anybody else? Gotcha. Study. Good for you. Rectum. 6 inches long. Anus. Exit. Okay. Moving on to this. Found this picture. This is a rectum and colon. It's fab. It's absolutely fantastic. It is a wine bar in Austria.
A wine bar?
Yeah, a wine bar. It made the presentation today. It also made the bucket list. I'm going to sit right here one day and drink wine for probably most of the morning. I can't wait. Yeah, the Rectum Wine Bar. So,
Where is it?
Austria. Yeah, and you can Google Rectum Wine Bar, and the first hit will be this.
Yeah.
You can find it. Okay, 4 layers of the colon. This applies to your diverticula, so mucosal, submucosal, the muscular layer, and the serosa, the subserosa part. So we'll talk about more of those and how they apply to. You guys know what a diverticula is, right? It's an outpouching within a hollow structure. Okay. And you can have them in the esophagus, and really you can have it anywhere, but we're talking about those of the colon. So. Mucosa, innermost layer, some mucosa, lots of good stuff. Again, this is histology or tissues and kind of a review, right? The muscularis, propyra, longitudinal. Here we go. Function of the colon. Transports through peristalsis. We know this like muscle milking, squeezing, and like moving things down the track. Reabsorb water in the colon. You've got some bacteria down there to help do all the stuff. Questions so far? Okay. You ever wonder where your stool hangs out before your bowel movement? Wonder no more. It's right there. Right there in the rectum. Okay, now here's what we kept talking about. The condition of having pockets or pouches in the wall of the colon. This is a diverticulosis, right? You guys understand the difference between osis and itis? Oh man. Okay, good stuff. So you can have a true diverticulum, or you can have a false diverticulum. The true diverticulums involve all 3 layers: the mucosa, the muscularis, and the serosa. I don't know how many level 1 questions you guys have at this point. That would be a great, question. I don't know if you have that. A false just involves, it doesn't have any muscular layer involvement. And a picture that I included was this one. It's a pretty good illustration. So you can see on the pseudo-diverticulum, or the false, that there's no muscular layer involved in the diverticulum. No muscle. Muscle. Questions? True, false. So there might be a true-false question on the test. Get it? So here's a barium enema. So you can see the little berries, little outpouchings there. This is from the inside. You guys get surgery rotation too. My surgery rotation was down in Durant, and we did probably 5 colonoscopies a day. And that's really what it looks like. I mean, exactly what it looks like. So you can see the little, this is Star Wars, like the old Star Wars. Like the little hut they lived in. It was like made out of clay and stuff. And the bedrooms were like little holes. True or false? True. You'll never watch it. I've ruined Star Wars for you. Diverticulosis is an acquired disease. You're not born with this. Uncommon in ages less than 40, and by the age 60, half people have it. more common with the Western diet. US is predominantly left-sided, mostly in the sigmoid colon. Here's an interesting fact. Asia, 70% are right-sided. Why? Asia's on the other side of the world. They're diverticular or on the other. Don't overthink this. Don't overthink it. Pathogenesis. Okay, so why, right? What's going on? Okay, this is kind of the how we get there. So there's pressure in the system. Areas of high pressure versus low pressure. Your colon just starts to get funky as it gets older, like everything else. With some motor dysfunction, high pressure. I was driving to work today thinking, chemistry people, where you at? There's a law, like in the inverse relationship between pressure and volume, right, in the cylinder or something like, it's like, what is it?
PV equals nRT.
Yeah, something like Lovelace or something, anyway. The point is, remember you've got the muscular layer, right, and all the peristalsis.
It's the ideal gas.
So if the volume contracts, the pressure goes up. So yeah, there you go. So higher pressure, and you can result in the outpouching. So you get an outer longitudinal muscle. Okay, I got another picture coming up. What you got, you got the longitudinal muscle that does the pulling this way, and then the circular, and you get a haustra, you know, like the little bands. So a single row of circular muscle between the haustra. So the greatest point of weakness is where the blood supply, the vasa recta, penetrate the circular muscle. And so that's the greatest point of weakness. If you got increased pressure, you're opening yourself up to the outpouching. And as a result, you have an associated artery with your diverticulum. That's important later in this talk. And here's a nice picture, right? So longitudinal muscle. So this is your longitudinal, you got some circular muscles, vasa recta, and there's a point where it punches through, and then guess what you got? A diverticulum. True or false? True. Is there a muscular layer? Right? So it's
Can't
false.
really tell.
That one is terrible drawing. This is fun. So, okay, this is interesting. So sigmoid diverticulum, you get more elastin in the muscle fibers, and so you get more kind of squeeze, more pressure, more diverticulum. That's true. Exaggerated accordion effect. Questions so far? Okay. More than 2/3 of people that have diverticulosis have 0 symptoms, which is why I like it so much. If you do have symptoms, if you're in that category that have symptoms, they're super vague. Intermittent pain, bloating, excessive flatulence, irregular stool, not like I had it today. This is me today before without the pellet-like stools. But yeah, I mean, that's but I'll get back to you later. So yeah, I mean, this is totally vague, right? So your differential diagnosis for diverticulosis, irritable bowel, and many others. But you got to rule out, right? You got to rule out some very vague stuff, right? You got to rule out colon cancer, right? So because you could have, and I'm talking about more, some bleeding associated with the diverticulosis, because there's a tip, in many cases there's an artery that runs that is associated with it. So you get a little bit of friability, you get a little bit of bleeding, then you get bleeding out of the rectum, you make sure it's not cancer. Okay, diagnostic test, very minimum. Familiar? Colonoscopy, CT. You're not going to see any labs. This is not going to cause any abnormal labs. So treating diverticulosis, you want to. The goal is to reduce the colon pressure. There's a couple ways to do that. Increase fiber, which increases transit time in the colon. Yeah, probiotics now recommended. Low residue diet is controversial. I don't even like residue. It's not even. You want to avoid corn, seeded nuts. That's kind of the low residue diet piece. And that's once you're out in practice, you hear like the GI will tell you, seeds and nuts, whatever. You know, like I'm not worried about that. That's what you hear. Now the diverticular bleeding associated with a diverticulum. So 15 to 40% of patients will have it. So the majority won't have it, bleeding with diverticulosis. It represents half all cases of lower GI bleed. So in those people that do have lower GI bleed, it's a pretty common offender. And really needs intervention if they're bleeding a bunch, fluid resuscitation, expand their blood volume, and you're good. And type and cross-match blood in case this person has that much bleeding and they need it. You know what they need. Okay, diverticulitis. This is where things start to sour a little bit. You have inflammation of a diverticulum. This is the most common complication associated with diverticulosis, and the second most common is bleeding. Okay, so how does this start? How do we get started with this? Initial event is what they call a microperforation. This is a small perforation. You think perforation, you think an open exchange with the peritoneal space. This is a microperforation, and there's a lot of pericolonic fat and organs. It's kind of a tight area, so it doesn't like free communicate with the peritoneum, and so yeah, you get a peridiverticulitis. So around that area where there's a microperforation starts to inflame, and you get a phlegmon. You guys know that word? It's just a generalized word for spreading infection, inflammation. Spreading, yeah. There it is. Suppurative paralytic. This is referred to as uncomplicated diverticulitis. So diverticulitis is a complication of diverticulosis, but if you have a microperforation, this is starting to sort of. It's an uncomplicated diverticulitis if it's a microperforation. This is where it starts to, anybody? Break bad, right? Walter White. A complicated diverticulitis. God, it's not even one.
I giggled.
Okay, you're a winner. Oh, thank you.
Yes.
This is where things got to get hairy. So you have a continuation of that phlegmon, that inflammatory process, and then it proceeds to obstruction. Okay, we'll talk about how, which is weird. Free perforation, never a good thing, and a fistula or abscess. These are all pretty bad things. Okay, so how do we get here? So you get your little Star Wars room, right? Your pouch, and then you got some hardened fecal material. This is my group. And it's like a fecal lith. Anyone? Heard it? A little doo-doo rock or something? It gets in there and it abrades the surface and starts to kind of get crazy, causing a low-grade chronic inflammation that becomes impacted. Okay, so it's not going to be widespread because it's associated with that fecal lith and the abrasion and the localized. It's not like it's going to be, if you've got diverticulosis throughout, it's no central cause, but it's typically one diverticulum. It's not like this, diffuse. Often in the sigmoid colon, progression to either, yeah, so it's going to go micro or macro. We'll talk about what that is. Questions so far? Good. Micro, like we talked about already, peridiverticulitis. Okay, so you get a little bit of a perforation, but it's contained in a localized area because of pericolonic fat or adjacent organs. Repeated episodes, fibrotic reaction, they ensheath the colon. This is how you get an obstruction. So You get the abrasion, you get the perforation, and because it's contained around with pericolonic fat or whatever it is, then it starts to inflame and it starts to constrict inward. Okay, so it's not like a free communication with the macro perforation, more serious. A free perforation, generalized peritonitis, or a walled-off abscess. This is just spilling nastiness out into your peritoneal space. And a walled-off abscess, you guys are familiar with that. You guys have had a respiratory, right? So you think of walled-off abscesses and TB and all that. So no good in the belly. Fistula formation. This is creepy. I've actually seen one patient, been exposed to one patient that reported poop in their pee. What's going on, right? So how do you draw a line between that? Well, you have a macro perforation adjacent to the bladder, that infection penetrates the wall of the bladder, and there's just this communication. It's like no good. You don't want that. Here is a CT scan showing what you might see here. The diverticula is pointed out there, and then you see how the bowel wall's thickened throughout. What questions have we got? Anybody think? Okay, good. Okay, so how does this present, right? Left lower quadrant abdominal pain in 93 to 100% of patients. So this is there's your sign, right? Left lower quadrant abdominal pain. I mean, what else is down there? And we'll talk about differentials in just a second. And fever, 57 to 100%. So lower left quadrant pain and fever, what do you think?
Diverticulitis.
Pass. And leukocytosis, you get some labs, you see a white count. Not reliable in the elderly, I'm sure that's well known here, and steroids. Nausea, vomiting, constipation, diarrhea, lots, just this party stuff right there. So nausea, vomiting, left lower quadrant pain, and pretty synonymous. Okay, so acute abdomen, you get that perf, that free peritonitis, you're going to have abdominal wall rigidity and guarding, and these people are miserable. I mean, and you'll see they'll come into the ER, if you haven't seen them already. Acute abdomens are no joke. And they look like this. Guarding, right? So whenever you start to even auscultate, they just don't want you near, and their abdomen is hard because they're trying to protect from palpation and percussion. Percussion tenderness, you know, you boom, boom, and they just jump off the bed. No, it's not good. Tender mass representing the phlegm. Never seen that, but it says it on there. I believe it, right? Bleeding is not typically a sign of diverticulitis. Confusing to anyone? Say again? I read up a little bit on it, and so you've got that localized infection and inflammation, and you've got that fibrosis of that mucosal lining, and right in here in this area, it really kind of keeps it from bleeding. But a happy little diverticulosis without any kind of inflammation, and they've got a vessel running through there. It just bleeds. I said something. You guys are typing up stuff. So here's your differential. Ischemic colitis, right? So pain, left lower quadrant, what else is down there? Some of the lady parts, right? So you gotta make sure you don't have an ectopic torsion. Carcinoma, right? We talked about that. Gotta rule out cancer in these deals. Volvulus, maybe that's the mass, the palpable mass, right? Maybe that's where you can grab a volvulus. Well, and abdominal pain is, it's tough. In clinic, it's tough, especially whenever you learn the transverse colon, you drop down. It's all over the place. Penetrating ulcer, kidney stone, urosepsis, right? So especially with the fistula, appendicitis, salpingitis, we understand these things. Go. Yeah. Okay, so how are you gonna work this up? Blood count, I think they said, remember leukocytosis, like 60 to 80%. UA, right, see if the urine's funky. I've gone flat and upright, looking for fluid in the peritoneum, plain film. White count typically elevated. UA may reveal pyuria if there's infection adjacent to the bladder. No good. So, and imaging. To confirm your suspected diagnosis of diverticulitis is CT, IV or oral contrast. Barium enema, no bueno. So you got somebody with a known history of diverticulosis maybe, and left lower pocket pain and fever, and you think they're a little bit acute, don't open a barium enema, because you can go ahead and perf them out, you know, just increases the pressure. Don't want to do that. Ultrasound, no bueno, because this slide says so. You know, you guys getting a lot of ultrasound in your education? It's like the next, I mean, it's like it's pretty much the thing now, but more and more. Okay, good. Treatment of diverticulitis. So what do you do for these people? NPO, right? We're going to not throw anything through that hallway that's already inflamed, got problems. Broad spectrum antibiotics, ciprofloxacin for 10 days, and avoid opiate analgesics. This is because those have been proven to increase intracolonic pressure. So they're going to want it. No good. Sorry, guys. Alternate oral antibiotics, Bactrim, Cenflexin, clindamycin, and doxy. Intraperitoneal or intravenous antibiotics. Here they are. Read them. Ampicillin, Unicin, aminoglycoside. You guys have Latassi here, right? This is her wheelhouse. She'll tell you about it. She taught me too. It's good. True. If significant inflammation is present, okay, so here you go. So if you've got a CT and it comes back and they're just in bad shape and they can't tolerate PO, or they're young or they're old or immunocompromised, then you might go with intraperitoneal treatment. So we already talked about NPO, IV fluids for resuscitation, antibiotics or IV parenteral analgesic. Mepridine is preferred, I'm sure. Dr. Latassi would approve. Okay. These guys turn around pretty quick once they get what they need, 48, 72 hours, and what NPO for 48 hours. So after a couple days in the clear, you can bring the PO intake back on, and then follow up with another 7 to 10 days of PO antibiotics. And after they're cooled off and back to normal, work them up. Colonoscopy or barium enema. So once they're not acute, you know, once they're not all raging, you can barium enema. Okay, once they have, with their diverticulosis flares up to diverticulitis, only 20 to 30% will have another event. If it happens a second time, you can probably going to have a third time, and elective resection should be considered. So go in there and resect the colon. Patients younger than 50 have a more aggressive course, and after a first episode of severe diverticulitis, more consideration given to a resection. Younger than 50. Okay. The GI people say, you have more than 3 to 12 months, we need to resect this. That makes sense based on the previous slides. Treatment for free peritonitis may require, diverting colonoscopy with Hartmann pouch. So divert out to a colostomy And the Hartmann pouch is leaving the distal portion of the colon intact. Just pouch it out and let it cool off. And then 12 weeks later, go reconnect. That's if you're free peritonitis, like just you're straight up. You're in trouble. Everything's flowing right into your peritoneum. Okay. Percutaneous drainage of abscess, CT guided. That sounds pretty sexy. I don't. This is GI stuff. These slides was a GI person developed it, and I made them my own. And I felt like that was pretty interesting. So if you can drain the abscess to a CT guided percutaneous drainage, and then 2-3 weeks later, resect. It's pretty sick people. Okay, questions about that? You guys are on it. You guys are going to do well. Okay. Polyps. A little bit of information about polyps. Our fun little friends. 2 types of polyps, neoplastic and non-neoplastic. So the neoplastic guys are the adenomas and the carcinomas, kind of the no fun. You gotta catch these things or they break back. I need another Walter White in there. Non-neoplastic, so just hyperplastic, mucosal inflammatory. We'll talk more about these. Carcinoids. Adenomatous. How do we get these, right? So this is up in your neoplastics. You have a failure in the step or steps of the normal process of cell proliferation and apoptosis. So unregulated cell cycle, that's cancer, right? Occurs and expands to the entire crypt. Cells are not sloughed normally and they accumulate. For your hyperplastic polyps, it's supposed to be due to the maturation of cells detaching from the epithelium. It's just an overgrowth of cells. Like that. There's really, observationally, there's no difference in the polyp. It's still got the same characteristics, it's just there. It's hyperplastic. A carcinoid tumor of the rectum, so you're starting to deviate from the normal looking mucosa there. So, this is good. This is good stuff. Major milestone, gastroenterology, was the hypothesis that the adenomatous polyps are pre-malignant. And basically what the rest of this slide says is that the adenoma curve, the cancer curve, they mimic each other, but they're 5 years apart, 5 to 10 years. So you got a huge window. You just got to get in there and screen and get them out. Preventing cancer, y'all. Word. Okay. Pedunculated colon polyp on a narrow stalk. I mean, who hadn't seen this? You guys will, yeah, you'll see this stuff if you're a GI and you're on your rotation, you get some colonoscopies. And if you're really good and your guys or your person is really good, maybe they'll let you burn. Probably not. This is your sessile, right? So it's a broad base. It's like a colon temple or whatever. Broad base. It's not on a stalk. And this is the flat colon polyp. Where's it at? I don't know. It's hard to see. Okay. This familial polyposis syndrome is just diffuse polyps. What do you do for these people? I mean, seriously, what do you do? I don't know. Okay. Hey, you guys ever see Weird Science? I'm so much older than you guys. Do you? Remember Chet? She turns Chet to a pile of poop at the end?
I do remember that, yeah.
It's just like that.
Yeah.
Google it, people.
Yeah.
So, pathology slide of the adenoma, right? This is the most common type, 86%. Kind of network of branching glands, and less dysplasia. It's just kind of homogeneous. It's just a network of branching glands. And then you got the villous colon polyp, 3 to 16%. So not nearly as common. The adenomatous glands extend straight down the center of the polyp. It's scary, like a finger. Lots of dysplasia here, so lots of dysplastic cells. And then you've got the combined. You get them both in one. Tubobilious colon polyp. 8 to 16% of adenomatous polyps. Size matters in polyps. The longer they live, the bigger they get, less than 1 centimeter. These are kind of the categories. Less than 1, 1 to 2, or greater than 2. The bigger they are, the greater likelihood they're going to be dysplastic. And the largest polyps are usually found in the distal colon. So you got 3 things. Okay, what factors will indicate that this has got malignant potential? The size, the histology, and how much dysplasia. So it's greater than 1, in which there's only 1 category. Greater than 1, so 1 to 2 or 2 increases the potential for malignancy. Is it more? Is the histology is it dysplastic? So degree of dysplasia, is it villus? Kind of what's in there? Earth shatters. Environmental causes, right? I'm reading this and I'm thinking, I've got polyps right now too to go with my diverticulosis. Low fiber, increased red meat, and increased fat. No, sorry. The familial adenomatous polyposis syndrome, we looked at that earlier. Of course, genes, right? Gene expression, and you win the cancer lottery with that kind of stuff. You're going to have an increased history, or you're going to have increased risk. Family history of colon polyps and colon cancer. This is important. Like any family history of cancer, to know what it is, at what age your family was affected, and then that impacts the screening for those patients. We'll talk about that briefly. Signs and symptoms of colon polyps. None, mostly some bleeding. If the polyps are bleeding, that's okay. Remember the bleeding diverticula, got to rule out the cancer because it's the same presentation. Got to make sure it's not one of them. Possible symptoms include flatulence, constipation, or diarrhea. Again, totally vague. Okay, detecting these things. Colonoscopy on an asymptomatic screen. Normally they're just having a screen. Oh, you had some polyps, and we removed them. And we'll talk about that. Or if you, okay, so you have a hemocult, right? So do you have blood in your stool? Yes or no? Hemocult will help you with this. If you've got blood in the stool, that's what you got to do. Find out what's going on. And then iron deficiency anemia. If you're working that up, sometimes you end up with an evaluation, detection of the polyps. Okay. How to diagnose? Colonoscopy is the best. Why? It's both diagnostic and therapeutic, meaning you find the polyp, you remove the polyp. Pretty awesome. Now, how good is your colonoscopy? Well, bowel prep dependent. If you don't do what you're supposed to do, stop eating, drink the stuff, or take the pills, because there's some new bowel prep stuff. If you don't prep right, then your study is going to be limited in what it can see. Your poop can hide the polyps, people. That's what I'm saying. Okay, and the endoscopist skill level. So it's important. You guys will see it. They'll come in and the GI will be running the colonoscopy, and they'll just get frustrated. Why are these people? Don't tell me this person didn't eat. Let's start right, because there's just stuff in there. It's not good. Virtual colonoscopy is like they put you in a CT machine and they just kind of radiate the crap out of you and then look through your colon. Why is this not as good? Because if you find something, guess what you got to do? Colonoscopy. You got to go in there and get it. There you go. Oh no. Okay, good. Barrier minima, not as acceptable. It detects less than 50. So why even do it? If you're going to go in there and find 3, and you think, is there 4 more in there? Capsule endoscopy. You guys know what this is? You swallow little pills on camera? It's cool. But how do you got it? It's just free floating in there, right? It's like a 360-degree camera. It's like a camera. And so what if it just doesn't point at you? That. Joke. Removal at time, okay, so how do you treat it? You remove it whenever you have your colonoscopy. You can get a biceps snare, cautery, or piecemeal. Oh, I got a picture for you. Some polyps require surgical resection due to, right, so some of them you can't get to get them out with the scope. Has anybody been on the other camera end of a colonoscopy? I don't want to ruin it for you, but it's pretty cool, right? So you got the whole snake thing, right? And then you can send tools down in there. It's pretty cool stuff. Tools like this. This is a snare, right? So it's got a little wire on there, and wrap it up, get it out. And they bleed, and then you send a bogey down there and keep it from bleeding if it's bleeding too much. They're going to bleed after their colonoscopy. The last slide, guys. There's like 15 different entities that put out guidelines for SRI. It's like the colon people, the rectum people, the cancer people, they all kind of, and this has AGA guidelines. They all kind of have a consensus of when to start. Without a family history, without symptoms, between the ages of 50 and 75 is when you screen. Fecal occult blood test, colonoscopy every 5 years. Where I'm at, we're a charitable clinic. We don't have just free colonoscopies laying around. We don't have it. So we do fecal occult blood tests starting at 50 and every 5 years, just as a first shot. Sometimes we find some blood, and then that ups the ante. We can go to the there's some resources we have, Healthwise for the Uninsured, and OU, and we'll take some stuff. And then we have to kind of advocate, like, hey, I got a 52-year-old, he's doing these kind of bloods, and don't you think he's got blood? All right. And then regarding follow-up, so for the folks with family history, this is where they, depending on what guideline you read, they vary some. So it's typically, if you had a family history, dad had colon cancer, diagnosed at age 52, they want you to be screened 5 years ahead of that. Fecal occult blood test. And I've seen the commercials on the TV, the little Cologuard guys, like, send me your poop, I'll tell you if there's cancer, you know. So if that becomes more cost effective, I need to look into that for my patients, because you know the manufacturer of these medications and tests a lot of times will provide those for free to patients if they qualify. Like for instance, hepatitis C. You guys have tested it? Yeah. It's on this test? Sweet. Well, so the Epcluses and the Harvonies of the world, you guys study that? No? Is it new antivirals? I don't want to be throwing a bunch of stuff at you that you're going to be tested with. I mean, I don't want to confuse you, but there's the new antivirals that are curative to 98%. Like you take this medicine, if you can take it, you take it, 98% it's curative for Hep C, which is big. 8 or 12 weeks, 120 grand. Our patients get it for free. So that's pretty awesome. So everyone's really excited about it. In fact, me and my supervising doctor going to Denver in 2 weeks to talk to the Charitable Clinic Conference, just to sound the alarm. Hep C is being treated for free. You better be doing it. Here's how we do it.
Where's that conference at?
It is in Denver.
Awesome.
Yeah, NAFC, the National Association for Free and Charitable Clinics.
Cool.
Yeah. Good question. Have a great day.